I'd like to introduce myself. My name is Marlene Hodges. I'm a Senior Health IT Advisor here at Telegen. And Telegen, through a contract and initiative with the Iowa Department of Human Services, is providing education and assistance to dentists in Iowa to aid with EHR implementation and with achieving meaningful use and understanding the EHR incentive program, and particularly the Medicaid side of the EHR incentive program. And we're going to get into details on those components here in today's presentation. In terms of objectives, we're going to look at the basics of electronic health records, the process of implementing, and some key resources. We're going to go into meaningful use and the EHR incentive program in the background, look at the objectives and measures of MU for 2016, give you just a little quick flavor for what's coming down the pike with the quality payment program, and then have some resources to share at the end as well. This is a lot of information in one presentation, so we'll have to move fairly quickly through it, but we know there are folks in dental offices here in Iowa that are still in the process of researching and looking into getting an EHR installed in their practice. There are others who already have a system and are looking now at what it means to meet meaningful use, what the EHR incentive program has been all about, and are ready to move forward there. So we have a very wide spectrum of dentists here in Iowa, all the way from folks that don't have the system to those who do and are ready to move forward. So we're covering kind of all that, so bear with me for this first little section for those of you who may already have a system, but I do want to look at some information in terms of EHRs and what that means and that process for those who are still working down that journey. So just we'll touch on those. Okay. We'll dive right in here. So we've actually, as I'm doing outreach and education for this program with dentists in the state that are needing some assistance, it actually has come up a few times with folks that don't really know exactly what an EHR is, some of that background, and just need some basic information. I'm not going to belabor a lot of this on these first few slides, but it's just good background and education information for those who are just kind of at the jumping off point with electronic health records right now. So I provided the Office of the National Coordinator for Health IT. I provided their definition of what an EHR is. In a nutshell, it's a real-time patient health record with access to evidence-based decision support tools that can be used to aid clinicians in decision-making. It can automate and streamline a workflow, getting all that clinical information communicated. It can prevent delays in response that can result in gaps in care, and it can support the collection of data for other uses as well. In terms of a definition of an electronic dental record, the American Dental Association defines this as an electronic health record, and it is a combination of processes and data structures used by dentists for purposes of documenting or conveying clinical facts, diagnoses, treatment plans, and the services provided. So that is just from a definitional standpoint what we're looking at for EHRs and EDR. In terms of why adopt an EHR, better information means better health care. Providers who use EHRs report tangible improvements in their ability to make better decisions with more comprehensive information. EHR adoption can give healthcare providers several things: accurate and complete information about a patient's health, the ability to quickly provide care. It can pull up information and fairly quickly within most EHRs, the ability to better coordinate the care that they give as you become more interconnected with other electronic services and connectivities with other healthcare providers that you deal with as a practice. That is a very, very big bonus there. And it's a way to share information with patients and their family caregivers. And the main goal of Health IT is to improve the quality and safety of patient care. In terms of the path to implementing an EHR, it can be a long one. It's daunting for a lot of folks to think about, okay, where do I even get started? There's a lot that I need to educate myself about. I need to educate my staff. I need to figure out where we're going as far as looking at products, then what do we do once we choose. So there are steps that have been laid out in terms of the path to help give you some structure to your process. Getting some structure to your process helps folks feel empowered that, okay, we kind of have a handle on what we need to do. We just need to keep working our way through the process to make this go as successfully as you can. So the first is to assess your practice readiness. There are different tools and resources to help you do that. 2, plan your approach. 3, select or upgrade to a certified EHR. Conduct training and implement that system. Achieve meaningful use, and continue with your quality improvement. There are some really good detailed tools and resources for these steps, and those are available at the website that I provided. It's the healthit.gov website. There's a lot of really good information out there on that website. I strongly encourage all of you to take a look at that for any of the steps that are outlined here. So this is beneficial to those of you who already do have a system and are working in steps 5 and 6 at this point, or looking to. So yes, please do check out that healthit.gov website for some good resources. Oh, I kind of forgot. Here's my screenshot of that. This is their homepage. And so there's the first tab, as you'll see at the top, providers and professionals. And it's just a nice, nicely designed and organized website for folks to go and get tools, resources, information to help them through this process. Just to give you a sample of some of the EHRs that are in Iowa dental practices, I've listed those here. You'll see that the sources, there's several that we were able to use, and one was the Iowa Medicaid through the CMS EHR Incentive Program, attestations. So folks do list which EHRs they're using. So through attestations, we know some of the products, EHR products that folks are using. And then the Iowa Health Information Technology and Meaningful Use Environmental Scan that was done in 2015, where folks shared what EHRs they're using in their dental practices. So this just kind of gives a sampling of some of the products going on out there in Iowa. This is kind of interesting information to know. In terms of the ADA involvement with EHR activities, I know some folks, from what we work with some of the dentists, they do look towards the ADA for information, but they have taken a leadership role in defining dental EHR functions, features, and capabilities through its work in the standards arena. They've been very involved in terms of there are these national groups of people in the industry that get input from folks such as the ADA, and they sit on these standards groups to help make sure that, you know, your specialties are being addressed in terms of what's going on with standards. The ADA has developed an internationally recognized dental terminology that's called SNODENT for short, systematized nomenclature of dentistry, for purpose of a standard terminology for capturing detailed clinical data in a coded, structured manner. So the EHRs that you're looking at, you want to make sure that the coding that is there and the standards that are there are nationally recognized standards and functionalities. So the ADA has been very involved in this. They have been leading in the development of dental information technology standards, and I've got some more information on that there, but just to provide some assurances that the ADA has been very involved in this. Okay, let's now turn our attention to the meaningful use component and look at some of the background. I won't go in, this program's been around since 2011, and it's evolved since then, so I won't go through all the minutia since 2011, but I do want to give folks some good background on what meaningful use is, where it came from, and kind of where we are with it right now. So meaningful use is the use of EHRs in a way that positively affects patient care. So where did it begin? It stemmed from the American Reinvestment and Recovery Act of 2009, ARA, the stimulus bill, as we all might remember it being termed. And the Health Information Technology for Economic and Clinical Health Act, or the HITech Act, this legislation was created in '09 as part of ARA to stimulate the adoption of EHRs and supporting technology in the U.S. And part of that is the CMS EHR Incentive Program, which was established for meaningful use. So that's kind of where it was born. Meaningful use was laid out in stages. The first stage was the data capturing and sharing. We have since moved on in the meaningful use journey. We are currently in stage 2 in the advanced clinical processes. And after that, beginning roughly 2018, when things move into stage 3, start looking at improved outcomes. So there are indeed practices out there, and of course across all different specialties, that have been engaged in meaningful use since the beginning in 2011. Others have come on board in the 5 years since and are well poised to continue on through stage 2 and into stage 3. The 5 health-related goals of meaningful use that we're looking at are to improve quality, safety, efficiency, and reduce health disparities, to engage patients and families in their health care, improve care coordination, improve population and public health, and to ensure adequate privacy and security protections for personal health information. So those are the 5 health goals that were established at the outset for meaningful use. So that's some of the background of where it came from. And so now we want to look at what we're talking about in terms of the Medicaid and the Medicare Meaningful Use EHR Incentive Program. So these two, of course, as you may know, and as I'm letting you know today, are tied together. So first of all, just as you can see here, the EHR Incentive Program, as it was laid out by CMS, is divided into 2 routes that a provider can take in terms of attestation for meaningful use. So you have the Medicare side of the program, and you have the Medicaid side of the program. I tried to lay out in this slide just some of the basics as to how they differ, and in terms of where you go to attest. So for Medicare, it's run by CMS. In Medicaid, every state runs its own program. So here in our state, we handle that here through IDPH. IME helps with that. And as you can see, the Medicare incentive amount, the maximum that you could get was $44,000. The maximum you can get through Medicaid is $63,750, and that's across 6 years. I want to, and I'm going to reiterate this a few times as we go through this presentation today, but you'll see in red here, actually is that, my screen's kind of playing tricks on me. I need to fix this. 2016 is the final year to initiate participation. So if you have not yet started the process of attesting to meaningful use, if you have purchased and implemented an electronic health record, a certified electronic health record in your practice, and if you have not yet initiated into the program for Medicaid, again, 2016, this is your last year to do so. So be looking at this and be planning to get this done for 2016 if you have not yet done so. And again, we'll touch on that a little bit more. So in terms of some other differences, there are payment reductions if you haven't attested for meaningful use on the Medicare side. On the Medicaid side, there are no payment reductions if you choose not to participate. So very distinct difference there between the Medicare and the Medicaid side. And then in terms of receiving an incentive payment for adopting, implementing, upgrade, you get that incentive payment for just getting a certified system installed and you're using it in your practice. You get that first incentive payment for the Medicaid side of the program. So that's not the case with the Medicare side, so a nice thing for Iowa providers who do qualify for the Medicaid side of the program. And then in all remaining years to get your subsequent incentive payments for Medicaid, you need to meet the objectives and measures for meaningful use, just as on the Medicare side. So, okay, so who is eligible to participate? I've got those outlined here too. So on the Medicare side, I've got those listed. On the Medicaid side of the program, they add in, so you'll see dentists are included for both. So as far as what we're, our focus today being on the dentist, you can qualify for either side of the program. So to give you an idea now in terms of, do I qualify for the Medicaid incentive program? Am I eligible? So first of all, you must meet the Medicaid patient volume threshold. And for dentists, that's a 30% Medicaid patient volume. And so this $21,250 in the first year, what that means is, like I mentioned, if you adopt, implement, or upgrade an EHR, and you hit this 30% of Medicaid patient volume, you can receive a $21,250 per dentist payment for your first year of attestation. And again, 2016, this is your last year to initiate into the program, so make sure you're looking at this if you haven't started yet. There is a needy patient volume for folks that operate in an FQHC or an RHC, so there's further details with that. And in terms of your patient volume, to see, do I hit that 30% or not? What data am I looking at to see if I hit that 30%? Well, the data you need to look at is look at a 90-day period from the previous calendar year to see, in this 90-day period, did I have a 30% or more Medicaid patient volume? So for 2016, for this year, you're going to look at that 90-day period from calendar year 2015 to see if you can find a 30% or more time frame for patient volume. In terms of the incentives, this is just a good graph that outlines, again, what the incentive payments are. So you'll see 2016, it's at the very far right-hand side of our chart, which again illustrates that this is the last year to initiate into the program. So $21,250 is your first per provider payment for adopting, implementing, or upgrading your EHR, and then $8,500 each subsequent year that you meet meaningful use and get attested. So that brings you to a maximum over those years of $63,000 per dentist that qualifies in incentive payments. So this is just a good illustrative chart here to see that step through year to year. Iowa Medicaid, the HIT EHR website, they have an excellent website. I provided the link to it here, and there are some really good tools, guides, and information available for you. Just to list a few, there's attestation tips and patient volume calculation assistance. So as I was mentioning a couple slides before, in terms of hitting that 30%, you know, you're gonna want to kind of educate yourself on how to pull that information. There is a provider patient volume template that can help guide you through looking at your data in a 90-day period and pulling in what you need to pull in to see if you can hit that 30% patient volume. And there's also an FQHC and RHC patient volume template as well. So, and again, I encourage you to go out to the website there and take a look at those tools. And there's also contact information on that website that if you have additional questions or get stuck in any other way with pulling your patient volume and looking at that, you can get a hold of the folks over there to give you some assistance. And so yes, please check out that website. In terms of where you're going for registering, attesting, and any related information, I've given you on this slide some of the primary websites that you need to go to. So I gave you the CMS EHR Incentive Programs website, tons and tons of information. This is the official site for information from CMS. And they actually have it laid out pretty well. Their left-hand navigation menu is laid out now even for the year that we're in and what you need to know for that particular year, as well as all the additional resources and FAQs and a host of other things to get your questions answered. The Medicare and Medicaid registration and attestation system, so where you will actually go to register to be part of the program and then do the attestation when you're ready for that. I've given that link there. The Iowa Medicaid portal for the program. It has a portal for Iowa folks doing the Medicaid side of the program, so that's listed. And then, again, the Iowa DHS Health IT Technology webpage. So there, that one is as well. So just want to make sure you know where you're needing to go to find all the information that you need. Okay, so there's some background on what the program is and some background on the eligibility piece. So now let's spend a little bit of time, and there's a lot of information to look at, but let's spend some time looking at meaningful use for 15 and 17 and then look at the measures. So here are your reporting periods. Just to focus on the purple for the sake of time today, 2016, if you are a returning participant, so you've attested to meaningful use or the adopt, implement, upgrade in past years, your 2016 for returning is the full calendar year is what your reporting period is. If you're brand new to the program and you are in your first year of doing the meaningful use measures to attest, then you're just looking at a continuous 90-day period anywhere between January and December of this year where you meet all the threshold criteria for the measures. So if, again, 2016 new participants, 90 days only that you need to meet. If you're a returning participant, the full year. And then it steps it out, too, for 17 and 18 for those of you who may be interested in that. Okay, so what are your objective and measure requirements? So there is a single set of objectives and measures plus your CQMs, which are clinical quality measures. So you have 10 core criteria for EPs, eligible professionals, and 9 clinical quality measures that you need to do. So we'll start to look at these now. Okay, so the objectives and measures, and these are applicable for 2015 to 2017. So here they are. Here are the 10. And I'm going to go, I won't read through this slide because I'm going to look at each of these individually just to give folks some information on what the basics are for each of the measures. But this is a nice just kind of summary list if you want to refer to this particular slide just to keep as a summary. And then your clinical quality measures, you're going to select and report 9. There are currently 64 to choose from, so you need to pick 9 out of 64. And the measures selected must cover at least 3 of the 6 available national quality strategy domains. So the 64, when you see the full list, are broken out into 6 different categories or domains. And I've got those listed here. And so basically they want you to hit 3 of those. So they don't want someone just picking all, say, number 6, clinical processes. And I'm going to do all of my clinical quality measures, I'm going to pick them, those are the only ones. They want you looking at least 3 of these different categories. So when you do your CQMs, it needs to fall across 3 of those. So hopefully that kind of makes a little sense to folks. Just really quickly on the payment adjustment facts, I'm not going to go really into detail on this. It's just more of an FYI type slide. But again, there are no Medicaid payment adjustments. There won't be any adjustments or penalties, so to speak, that you, for your Medicaid reimbursement that you get. That is, there are none. In terms of Medicare, however, there are, starting 15, those adjustments started for folks that haven't met meaningful use yet. And so now, so in 15 there was a 1%, they got a 1% reduction in what you get paid. This year it's 98. 17, 18 it goes down to 97. So, you know, that's a 3% reduction in what you would be getting paid for your Medicare physician fee schedule there. And again, just a couple points there about that adjustment. So I don't want to go too far into that at this particular time, but it's referenced here in the presentation. So hardship exception, if you happen to see a lot of Medicare patients in terms of Part B, and I do not, from what we know, that's not common in dental practices, but there is a hardship exception application that you can fill out by July 1st so that you can give them under these particular categories of why you want to have an exception from getting that penalty. You can fill that application out and submit it by July 1st. All right, so in terms of the objectives and measures. So again, earlier, a few slides back, I had that just basic at a glance list. So now let's go into the actual measures themselves and kind of step through each of these and just kind of the basics of each one. So the first one, protect electronic health information. What does this one entail? So you are going to conduct or review a security risk assessment. It needs to include encryption of EPHI created or maintained by your certified electronic health record. And there are no exclusions. You can't take an exclusion and not do your security risk assessment. There is a link that I've provided here to a security risk assessment tool that was developed by ONC. This was requested a couple of years, or fairly early on in the program, actually. Smaller practices, as opposed to some of the larger practice groups, needed a place, some reference point in terms of security risk assessment. The bigger groups, their IT and legal departments, they were able to do this, but the smaller groups felt like they needed some more guidance in this area, so the ONC does have an SRA tool that's developed and out there. So please take a look at that if that's something you need to be considering outside of what you may or may not have. The second objective is clinical decision support. So this objective is to use clinical decision support to improve performance on high priority health conditions. And there are a couple of measures as part of this. The first measure is you need to implement 5 clinical decision support interventions related to 4 of your CQMs. So they need to tie back to your clinical quality measures at a relevant point of care for the entire EHR reporting period. And then it does go on to say if there are not 4 related to your scope of practice, then they need to be the high priority conditions. So first one is you need to implement 5. And these can be a variety of things, whatever is applicable to your patient population. And so it's not anything that should be difficult or outside the realm of what your providers are doing in your EHR. But again, that's your first one, is to do 5. The second measure is to enable and implement a drug-to-drug and a drug-to-allergy interaction check for the entire reporting period, so that your system is alerting you that there's a drug-to-drug or a drug-to-allergy interaction, so that the provider knows, oh, maybe that is not the drug that I need to be prescribing for this patient for XYZ reason. Now, there is an exclusion for this particular one, and that is any EP who writes fewer than 100 prescriptions. They can exclude from Measure 2 of that one. So, and if you're wondering, for those of you who are still kind of getting your feet wet with EHR, certified EHRs do have the ability already built in terms of the drug-to-drug and drug-to-allergy. It needs to be turned on. It cannot be turned off. I don't know yet in all my years working in meaningful use that I ran across anyone who has that turned off. So typically it's just default to be turned on. So, okay, computerized provider order entry, CPOE. Use CPOE for medication, laboratory, and radiology orders directly entered by any licensed healthcare professional that can enter orders per state local professional guidelines. So the first one, so that was the objective. So then it is broken down into 3 measures. The first one is for the medication orders. So you need to be using CPOE, so ordering it within your system for 60% or more of your orders. For Measure 2, for lab orders, that needs to be at 30%. And the same for radiology orders. That one is at 30% as well. There are exclusions for all three of these, however. So any provider who writes less than 100 medication, laboratory, or radiology orders during the reporting period may exclude from any of those measures. There is also an alternate exclusion for Measure 2 and 3. And that means an alternate exclusion is a little bit different than the standard exclusion that you just looked at. An alternate exclusion applies just to providers who were scheduled to be in Stage 1 in 2016. So what that means is this is your first time attesting for meaningful use. You may claim an exclusion for Measure 2, so the lab orders, this year. And you may also claim an exclusion for Measure 3, which are the radiology orders, if you are to be in Stage 1, or were supposed to be because it's your first time doing the measures. So those are additional, they call them alternate exclusions. It's basically an additional exclusion that you can look at if that applies to you. So a couple different things there to just kind of make sure that people don't fall in a category of being ineligible to attest because of the Measures 2 and 3 for lab and radiology. Okay, number 4 is EPrescribing. The objective here is generate and transmit permissible prescriptions electronically. And the measure is 50% plus of permissible prescriptions written by the EP are queried for a drug formulary and transmitted electronically using your certified EHR technology. And there are a couple of exclusions here. If the provider writes less than 100 permissible prescriptions during the reporting period, you can take an exclusion for this measure. And if the provider does not have a pharmacy within 10 miles of your practice that accepts e-prescribing, that is your second exclusion. So a couple things there just to keep in mind, but otherwise this particular measure is pretty straightforward. Okay, health information exchange, number 5. So in this objective, the provider that transitions or refers their patient to another setting of care or provider of care provides a summary of care record for each transition of care or referral. And so again, looking at the measure, the provider that refers must use the certified electronic health record technology to create a summary of care record. And again, like many of these other measures, your certified EHR system can and should be able to create the summary of care record for you so that you can provide it to the patient who is transitioning to another provider for whatever reason, and so that you can count that patient in your numerator and get credit for that in meeting this measure. Electronically, and so the other bullet point here for this one is that the provider must electronically transmit such summary to a receiving provider for 10%, greater than 10% of transitions of care or referral. So the second component is that you electronically send that to whichever provider you're sending your patient to as in terms of a referral. There is an exclusion for this particular measure as well. So any provider who transfers a patient to another setting or refers patient to another provider less than 100 times during the reporting period, you can exclude. So if your reporting period is the 90 days, so it's your first year in 2016 to attest to meaningful use measures, if during that 90-day reporting period you don't have 100 patients that you referred during that particular time, you can exclude from that measure. There may be an instance too where you are doing your second year of meaningful use, so you're needing to, or beyond, and you're needing to attest for the full year. You may have less than 100 for the full year. Just depends on, your the particular provider and such. But again, there is an exclusion for this particular measure as well if it should apply to you. Number 6, patient-specific education. The objective here is to use clinically relevant information from certified EHR to identify patient-specific education resources and provide those resources to the patient. So the measure then is patient-specific education resources identified by your EHR are provided to patients for 10%, more than 10%, of all unique patients with an office visit seen by the provider or admitted as an inpatient or EHR or ER during the reporting period. So it's a 10% minimum on this one in terms of providing your patient with those patient-specific education resources. So this is looking at getting your patients educated on their care, their diagnoses, their, whatever it may be that you're providing that education to them. This one has an exclusion. We always find this to be a rather odd exclusion, but that is any provider who has no office visits during the reporting period. I know there's more background to what that exclusion is all about, but anyway, there is an exclusion from what we've ever seen that's never been applicable to anybody we've ever worked with, but they're nevertheless in the final rule. Okay, moving on, medication reconciliation. Here, what we're looking at is the provider that received a patient from another setting of care or provider believes an encounter is relevant, performs medication reconciliation. So speaking with your patient and reconciling those medications that they're on and making sure that your system is reflective of the medications that your patient is taking. So the measure is that the provider performs med reconciliation for greater than 50% of transitions of care in which the patient is transitioned into the care of your EP. So as opposed to the other one where you're sending a patient to a different provider and you're giving them a summary of care, this medication reconciliation applies to patients that are coming to you from another provider or setting in some sort that you're reconciling their meds. So just kind of that distinction between referring out and folks coming in. Exclusion on this one is any EP who is not the recipient of any transitions of care during their reporting period. So if you didn't have anyone in your reporting period for either 90 days or for the full 12 months that came in from another provider, you can take an exclusion there. Okay, patient electronic access. The objective here is provide patients the ability to view, download, or transmit, you might hear the term VDT for short, view, download, or transmit their health information within 4 business days of the information being available to the EP. So what are the measures? There are 2 for this one. So the first one is greater than 50% of all unique patients seen by the provider are provided timely online access to their health information to view, download, or transmit, if need be, to a third party. So what this means in kind of layman's terms is your certified electronic health record system needs to have essentially a patient portal where your patient has their own login to see some of the basic and relevant information of their care. These patient portals, it depends and varies a lot from EHR vendor to vendor. Some are just inherent and part of the main system that you're using. Others are kind of an add-on application feature that you would use for your patients to have a portal login. Just kind of depends on how that's set up from EHR vendor to vendor. But this number 8, patient electronic access, is essentially looking at patient portal for your patients and their families. So looking then at the measure number 2 on this slide, at least one patient or their authorized representative, so for instance a family member, seen by the provider during the reporting period needs to view, download, or transmit his or her health information to a third party during the reporting period. So you need to have at least one patient or their family member, et cetera, during the reporting period needs to go into their portal and actually view, download, or transmit any of that information. So again, one patient there, and otherwise half plus of your unique patients need to have access to their health information. So good measure there. Number 9, secure electronic messaging. The objective, just one measure here, The objective is to use secure electronic messaging to communicate with patients on health information. And so the measure is at least one patient, so just one, seen by the EP during the reporting period was sent a secure message using the electronic messaging function or their representative, or in response to a secure message sent by the patient. So again, similar to the portal, and oftentimes as part of the patient portal, a certified electronic health record technology provides secure messaging with your patients. And again, this might be an upgrade to what you have. You might have had your EHR installed for the last 3, 4, 5 years, however long it may be, but you've never broached the topic with your vendor about getting a patient portal installed for it. That includes the secure messaging. So those, if you haven't met Meaningful Use yet and have plans to do that and get work forward on that, those are conversations you want to have with your vendor to get those things off the ground. There is an exclusion for number 9, and this is any EP who has no office visits during the reporting period or conducts 50% or more encounters in a county that does not have 50% or more of its housing units with 4 Mbps broadband availability from the FCC. If you need more information about that, let me know. There are a few little pockets in Iowa that don't have more than 50% of its housing units with broadband availability. FCC has a website that you can go to determine if you would fall in that particular, those particular areas or not. So that's secure electronic messaging. And number 10, the public health objective and clinical data registry reporting. The objective here is the EP is in active engagement, as they call it, with the public health agency to submit electronic public health data from your system, except where prohibited, blah, blah, blah. So the EP must meet 2 of the measures, and we'll go over what those choices are. If you're wondering what active engagement means, there are several different ways active engagement can play out, and they've outlined 3. The first one is that you've completed registration to submit data within 60 days after the start of the reporting period. Second is in the process of testing and validation of electronic submission data. And 3, you are actually electronically submitting production data to the PHA or CHR. So we'll get into that a little bit more here. So here, I'll jump back. So you have to meet 2 of the measures. And so here are, I'll go through each of those with a little detail. So the first measure, option 1, is immunization registry reporting. So you're in active engagement with the state's public health agency to submit immunization data, and here in Iowa we have that. I'm not going to go too much into some of these just because I know with your scope of practices, this is not something that really is something that you're looking at with your patients. The second one is syndromic surveillance reporting. This is something, too, that is not really applicable at this time for Iowa providers. And so then let's look at measure 3, specialized registry reporting. The EP is in active engagement to submit data to a specialized registry. This may apply to dentists. You may have specialized registries for dentistry that you are submitting some data to for analysis and any of your QI efforts. There are exclusions here. So any EP meeting at least one of the following criteria may be excluded from the specialized registry, and those are outlined here for you. So there are several different exclusions you can take. Okay, so you might all be a little like deer in the headlights when it comes to this public health objective, which is totally understandable because it's the muddiest of all of them, and CMS really had to do some additional education when the final rule came out in terms of giving some more description around some of the exclusions for it and what people need to be taking away from it and what they need to do. There are alternate exclusions for 2016. So EPs that are scheduled to be in stage 1 and 2 in 16, you need to attest to 2 measures from those, but you can claim alternate exclusions. Just as an FYI, a lot of the folks that we helped attest earlier this year for the 2015, and now that they're looking at the 2016, as we started looking at that with them once they got their 15 attestations done, most folks are looking at these exclusions. So don't get too wound up and worried about whether you can meet the public health objective at this point in time, because once you get a chance to really look at those exclusions, I think you'll all be fine with what that looks like for you, particularly for this year with the alternate exclusions and such. So again, looks daunting, but when you boil it down, those exclusions are going to apply to a lot of folks. So, all right. Looking ahead to the CMS Quality Payment Program and macro-MIPS, I don't want to spend a lot of time here, but we have been finding that it's important for folks, especially those who are a little further along in this journey, that just to know what the landscape is going to be looking like here in the coming year, 2, 3, and beyond. And so I just want folks to have a very high-level understanding or familiarity with what some of the terms are. So that's why I've put a few slides here so you can start kind of just that education on what this means. So CMS has rolled out the Quality Payment Program. You'll hear it QPP for short, for its acronym, and it's part of a broader push towards value and quality. So in 2015, the Department of HHS announced new goals for value-based payments and advanced payment models for Medicare. And again, dentists, with Medicare, not so much, but the way these things typically end up rolling out is private pay often follows what Medicare starts to do and such. So again, just want you to have a familiarity with what that is in case you're hearing that. I gave some more information here in terms of the Quality Payment Program. I won't go through each and every one of these, but it does repeal the sustainable growth rate formula that has been used, and it streamlines. The second bullet point is really good to know. What it does is it streamlines multiple quality reporting programs into the new merit-based incentive payment system, and that's called MIPS. Again, I won't spend a lot of time. This is here for your FYI, as for those of you that are going to be looking closer at it. But the MIPS is basically combining the PQRS and the value-based modifier and meaningful use. There was some just buzz going around, I don't remember, maybe it was in the fall, about meaningful use is going away. We won't have to do it anymore because MIPS is coming out, so we can stop worrying about it. Meaningful use as its own standalone program, it's not going away anywhere. It's just getting rolled up as part of this MIPS, this merit-based incentive payment system. So again, not going away. It's just being rolled up to streamline these programs. So just, again, want to make sure that we start getting some of that awareness out there. I've provided some links to resources, to additional resources. I know I gave you some earlier too. Here's your EHR incentive program website and the direct links to what the 2016 program requirements are. So I went through pretty quickly those 10 objectives and their associated measures. There are really good specification sheets that CMS has put together for each of those measures. So and it gives the full nitty-gritty details on what information it is that they're going to be looking at, what qualifies, and especially looking at those exclusions. It steps all that out for you. So go out to the CMS website and start looking at those if you're at the point in time where that's where you're ready to move forward into. And again, if anyone should need that hardship exception that's due by July 1st to avoid the Medicare payment adjustment, I've provided the link there too. Here is my contact information. I've also provided the contact information for Carrie Ortega. She's over at Iowa Medicaid Enterprise. She works with the Medicaid EHR incentive program over there. She is on the call today as well, so thank you, Carrie. She's an excellent resource as well for any questions you might have on the Medicaid side of the program and getting registered and attested and all that good stuff. So I'm going to go ahead and unmute everybody's lines right now, and if anybody has any questions, we'll be glad to take those. So let's see.
The leader has unmuted your line.
Okay. I think and I hope I've unmuted the lines. I hear a little bit of background, so I think I got that done successfully. So if anyone has any questions, feel free. I should say, as my contact information is up on the screen here, if you would like assistance with your EHR implementation process, if you would like assistance with the meaningful use and the incentive program side, please do contact me. That's what we are here to help with. And then we can start working together on what your needs might be, and we're happy to help. So please do get a hold of us. Carrie reminded me that we do have a couple additional webinars coming up. We're going to have another one in July and then in August as well. So we will get those communicated out to you. Okay, Carrie, remind me, no, you're still on. Remind me the order that we're doing the July and August in terms of our topics. We were going to do one for EHR selection specifically, correct? I don't have my little list of those. Okay, EHR, yes, in July, and attestation is the topic for August. Thank you, Carrie. So again, please stay tuned for the informational letters that will come out regarding those July and August webinars. Those will be a little more focused, again, one on the EHR side and then on the attestation side. So if those are topics that you need to be tuning in for and getting up to speed with, please watch for those and get registered and join us for those. We'll look forward to having many of you on that.
Thank you for the presentation.
You're very welcome. We're glad to provide it for you. We hope it gave you some decent information and some good resources. And again, we do encourage any of you to individually reach out to me for any kind of assistance and guidance. We're happy to be working with Dennis in Iowa and being able to provide this technical assistance to folks.
This is Carrie from Iowa Medicaid, and I'd just like to give a reminder as well on the website for the DHS Health IT and EHR Incentive Program. There's lots of great information out there, especially in calculating your patient volume, expectations of what we're looking for with the patient volume, as well as the other meaningful use and clinical quality measures information that you would be submitting to meet meaningful use. So if you have any questions or need additional resources, please continue to watch the DHS HIT website, and I will also be providing more guidance sometime over the summer and hold a webinar myself for all providers, just updating folks on the patient volume templates and guidance that IME can give providers on meeting those meaningful use requirements.
Thank you, Carrie.
This is Jill Travis in Shenandoah, and I've spoken to you several times. You've been so helpful, and then tuning into this webinar has been very helpful. So I'll continue with our attestation, the calculation for the patient visits, the patient volume, and I appreciate all the good information, and I will stay tuned to the website and future webinars as well. So thank you for all your help.
Great. I'm so glad it's been helpful.
Oh, yes.
Thank you. Any other questions?
Hi, it's Robin from All Care in Council Bluffs. I was wondering if we could have access to the slides that we viewed today.
Yes. Carrie has those posted. Let me see. I think I have them. Let me see. 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 let's see, what's the best way to have?
Marlene, are you able to send in the chat box to all attendees and just give them the link to the DHS HIT site there?
I think so. Let me.
I wasn't able to send anything to all attendees, but I
think send to
that.
Yes, I think I can. Can you? Okay, I need to. It's kind of a long link though. I need to go and find the slide that I have it on. Do you know it off the top of your head, Carrie? Oh, there it is. Can everybody check their chat box on the screen for the WebEx? I just copied and pasted the link and put send to all attendees. Can you guys tell me if you were able to see that?
This is Carrie at Colfax Dental. I can see that.
Okay. Robin at AllCare, are you able to see that?
Yes,
in the chat box?
Yes, I do.
Okay. So maybe copy and paste that and bookmark it or notepad it or just somewhere where you can grab it after we disconnect the call.
Okay, got it.
Otherwise, just get a hold of me or Carrie at our email here on the screen too, and we can send it to you email if that shouldn't work your first route.
Okay.
Yeah, it's a great website. Yeah, go ahead.
You can subscribe to the DHS HIT website page updates. At the very bottom of the page, it says to subscribe to this page's updates. Please log in, and you can do that too.
All right. Thank you.
And then the webinar slides are underneath the news and announcements. You'll see new resource for Iowa dentists participating in Medicaid.
It's a good website. I encourage all of you to go out there. Carrie gets some good updates posted to that website pretty regularly. So maybe bookmark it in your whatever search engine you use, so then you can just grab it and check it periodically. Well, we thank all of you for taking your time today to join us on the WebEx. We also want to let you know, and as I mentioned, I guess at the beginning of the call, now that I remember, this is being recorded and it will get posted. So a notice will go out in terms of the posting and where the link to go and find the posting so that you can listen to it again or have colleagues that need to listen in to have them access that as well. So stay tuned for that information. And again, we thank you and have a great rest of your day, everyone.
Thank you.
Thank you very much.
Thank you.
Bye.